hope you're having a good week. Today's video is about ambivalence. So just before we get into a more explicit discussion of the risk assessment, including risk factors and protective factors, there's one additional topic that I want to talk about that is important, I think, to keep in mind. It cuts across all of the issues about suicide. And that's ambivalence, and that is that people who are suicidal are ambivalent. They have mixed feelings. They feel both that they want to live and they want to die, and I want to talk a little bit more about that. So ambivalence, in a more general sense, simply meaning, having feelings on both sides, or not being able to make a decision because you feel pulled to both sides, or thoughts on both sides. Ambivalence is mostly mixed feelings. And we come across this in everyday life a lot. So, one simple example is that you're out for dinner with some friends. This is pre-pandemic days, so we're not worried about masks or sitting far apart. You're out to dinner with friends, and you can't decide what to order. And the server's standing there getting impatient, and the other people at your table have already ordered, and you're not sure, and you're looking at the menu, and you can't decide between the salmon and the steak. And you go back and forth, so basically in terms of ambivalence, you're pretty close to 50-50. But the server's looking impatient, and the people at your table are looking impatient, and so you just decide impulsively, I'll take the steak. And the server goes away, and the people turn back to the conversation, and immediately what happens? You think, oh, I should have got the salmon, right? So that illustrates what happens with ambivalence when a person is close to 50-50 about feelings on both sides, or a decision, or conflicting thoughts about something. When they act on one side, it causes a temporary but very predictable surge up in the other side. We also see this in something that's called buyer's remorse. Buyer's remorse is the feeling, a similar feeling that a person gets after they bought some expensive item. It doesn't happen with small things, but certainly in buying a car or a house or a major appliance, it's like doubt comes in. Did I do the right thing? Did I make a mistake? And in fact, it's so prevalent and so frequent that Illinois state law has even included essentially a buyer's remorse clause when you get a mortgage. So when you get a mortgage, you're taking out a big loan to buy a home or a condo or whatever, thousands of dollars. And at the closing, which is when you sit down and sign all the papers to actually make it take effect, one of the things that they bring you is a 3-day notice of rescission, which basically means you have 3 days to change your mind. And if you change your mind within those 3 days, you sign another form and send it in to the title company, and the whole deal is off. You haven't lost any money. It just cancels the whole thing. And this is in Illinois state law. So the idea being that buyer's remorse when a person buys a house is so common that they build in a 3-day period for people to think it over and make sure they've made the right decision, right? But ambivalence is confusing to people, so especially when it comes to feelings, maybe a little less so when it comes to thoughts, that people feel like they have to be, consistent or quote-unquote logical, and so they try to decide which side they feel. Do I feel this or do I feel that? When often, it's a combination of both. So I ran across this some years ago. And let me tell you a short little case example that was kind of enlightening to me to see how this operated. So I saw a client who was actually in a crisis as well in my private practice, who came to see me and was very depressed, very upset, stayed home from work, couldn't function very well. And ostensibly, the superficial precipitating event was the death of her father. So she proceeded to tell me a story about how she and several of her siblings lived with her parents when she was very little, but her dad was really irresponsible. He would go out, stay out all night, sometimes go out and not come back for the whole weekend. And as time went on, she's still little, but as the years went on, he would spend more and more time away from home until finally, and she was still a little girl, under 10, I believe, that he went away and never came back. They never saw him again. He basically totally abandoned the family. And later they heard through a cousin that sort of stayed in touch with him that he had moved to, like, I don't know, Georgia or Florida or Alabama or somewhere, and had met a woman and had married her, even though he was still married to my client's mother, and started a whole other family, had a couple other kids. And this went on for years and years, right? My client is now, how old was she? Maybe 30 to 35. So he had been gone for many years. But throughout those years, she thought about him. And at times she thought, I should get in touch with him. He's my dad. And through that cousin, she figured she could probably figure out how to get a hold of him. But then she would think, well, no, he's the one that abandoned us. It's up to him to get in touch with me. And so she'd go back and forth, and she never did get in touch with him. And then, as I mentioned a minute ago, what threw her into a crisis was that she got word through that same cousin that stayed in touch that he had been killed in an auto accident. He was not that old, it wasn't like my client was expecting him to die at any time now. I think he was only, mid-50s or something like that. But he died in a car accident. And that threw her for a loop, because all these years when she thought, I should get in touch with him, or, well, no, it's up to him to get in touch with me, she always thought, well, okay, I'm not going to do it now, but I have time. I can do it later. I always have time. And then, obviously, in this situation, the time had run out. So in the session, she goes, I'm not sure exactly what I'm totally upset about. I'm really sad that he's gone, of course, but, I'm angry that he never contacted me. And basically, I can't decide whether I love him or I hate him. And without really thinking that much about it, I said, well, of course, you love him and you hate him. You don't have to decide. You don't have to choose one or the other. And, if she were a cartoon, it was like a light bulb would have gone off over her head. So it really, and actually resolved much of her crisis, was to realize when I said that was true, that she didn't have to decide whether she loved him or hated him, that she could feel both, and that was totally legitimate. And we see that in everyday life a lot. Now, one other final aspect of ambivalence is that when people get into conversations with other people about some topic with which they feel ambivalent, they often try to make the combined conversation reflect their own ambivalence. So, and I have this, in our social work field, if a client has depression, has major depression, then I typically think that they should receive psychotherapy and medication. And so if I'm talking to a bunch of therapists about depression or issues with depression or whatever, I find myself kind of throwing in the medication idea because no one else is really mentioning it. But on the other hand, if I'm talking to a bunch of psychiatrists and they're just talking about medication, then I feel the need to throw in some comments about psychotherapy, right? Because I feel mixed and I want the conversation to reflect both sides of what I feel. I had another little mini example of this come up the other day. With suicide, for the longest time, I've thought about the relative contribution of mental illness and stressful life events. And as we will talk about later in the semester, the real emphasis, until just recently, the real emphasis for at least, 30 years in the mental health field, in the suicidology field, is to focus on mental illness. And allegedly, the rates of 90 to 95% of all the people who die of suicide have a diagnosable mental illness. More recently, that's beginning to change. And so throughout these years, on a lot of occasions, I find myself talking to other people who are involved in suicide prevention, and I'd want to push and argue for the importance of the stressful event, not just the mental illness. And then more recently, that's begun to change. And on one of the listservs I belong to, I've been reading a number of contributions from people that are really focusing on stressful life events and societal oppression, and really downplays, and in some cases really argues against the mental health aspect of suicide. And so I find myself feeling strongly, no, wait a minute, don't forget about the mental illness side, right? So again, I would like to make the conversation reflect the mixed feelings that I have. And this is very common in everyday life as well. So now what about ambivalence regarding suicide? Well, there's a number of examples of this. One of which is it's very common for people to attempt suicide and then rescue themselves. People cut their wrists and they call 911. People try to asphyxiate themselves in their car in the garage, and they sit there for 3 or 5 minutes. Then they turn the ignition off and open the door. In many cases, people initiate a suicide attempt, and that immediately leads to a refocus. That their ambivalence tilts toward the other side of wanting to live, and it gets reflected again in this common thing of people taking an overdose, cutting their wrists, beginning to hang themselves even, and then quote unquote changing their mind. I don't like the idea of changing your mind, because it sounds like you were I'm all die and now I'm all live. It's more like the person had mixed feelings, and acting on the die side made the survive side get stronger. I know 2 examples of people who tried to kill themselves in an emergency room, in the emergency room when I worked. In the early days, a lot of the ER physicians were surgeons, and this was even before they had an emergency medicine specialty. And they would often take a tough guy approach. I've been here all day trying to save lives, and you come in trying to take your own life. Here, let me show you. If you want to cut your wrists, cut this way, not this way. The tough guy approach, the shock approach. And I know, 2 patients in the ER who got that shock approach and then were left alone. One of them took an overdose of pills that she had in her purse, and the other one broke a glass IV bottle. Back in those days, the IV bottles were glass, and slashed his wrists. And in both cases, you could sort of think of it as oh yeah, well, I'll show you. But it's also another way to look at that is that their suicidal impulses were minimized, which made them stronger, at least on a temporary basis, and led to the actual suicide attempt, or at least suicide gesture. You figure if you try to kill yourself in an ER, it's probably a pretty safe place to do it in, but yet it's an expression of that side of the ambivalence. The other example I would bring up is that it's very common for people after they've made an attempt that could have been earlier I said people who rescue themselves, and now I'm thinking about people who have made more serious attempts, have been brought to the ER, and then when you interview them afterwards, very often they say they're really glad to still be alive. Now, this isn't universal. I think in my experience, though, it's 80%, 85% of people who I saw after making a suicide attempt were glad to be alive, and sometimes they can't believe that they did it, and they don't know what came over them, and things like that. They're very glad to be alive, and we're going to talk more about that as time goes on. Now, another point here is the thing that you'll hear people say, mental health professionals say, well, if someone really wants to kill themselves, there's nothing you can do to stop them. If someone really wants to do it, there's nothing you can do. Which is sort of true on one level. Of course, anybody can do anything they want, and people find ways. But on the other hand, I really object to this, because often it's what mental health professionals say after a client has died of suicide. So it sort of feels like a rationalization, or what we tell ourselves to reassure ourselves that well, there really wasn't anything we could have done. And I don't think that's true. And now, I don't think every suicide is preventable necessarily, but many of them are. And the idea being there really isn't anybody, or there's very few people who just really want to do it. They don't. They really want to do it, and they really want to live. They feel both things at the same time. So if someone really wants to do it, is a rare occasion. People are ambivalent. Most people want to be stopped. If they can't stop themselves, they would like to get help and get someone else to rescue themselves. So my friend Peggy worked in a crisis line years ago in Detroit, and she tells the story of she was on the crisis line one day, and a woman called up and said, I really don't want you to try to talk me out of suicide or anything like that. I pretty much decided I want to do it, but I do want to talk to someone right up until the time that I do. It's going to be soon. And I think, if I recall correctly, she wouldn't tell Peggy how she was going to kill herself, but she was going to do it fairly imminently. And they talked for maybe 5 minutes, and the caller stopped and said, wait a minute. Are you tracing this call? And Peggy said, no. In fact, we don't believe in doing that. We believe in self-determination, and I certainly would try to talk you out of killing yourself, but we believe in self-determination. If that's ultimately what you decide you really want to do, then we're not going to try to stop you. Now, actually, that wasn't true, and she had signaled a coworker to start tracing the call. But this was back in the days before caller ID and everything, so tracing a call was a big deal. It took, I don't know, a half an hour in good times and an hour and a half or 2 hours in bad times to trace a call. You had to get the police involved in some cases. They had to have technicians from the phone company come out. It was a big deal. And it's also not true. There are some crisis organizations, I think the Samaritans in England may be one of them, that do take that radical self-determination view. But Peggy's crisis line was not like that. They would send the police or an ambulance when necessary, but she didn't say that. So anyway, they talk a few more minutes, and the second time the caller says, "Wait a minute, are you tracing this call?" And Peggy again says, "No, I explained to you, I'm not doing that. We don't believe in that. I'd like you to not kill yourself. I'd like us to find another way, but if you want to do it, I'm not going to try to prevent you." Okay, so they go on and talk another few minutes. And for a third time, the caller says, "Wait a minute, are you tracing this call?" And Peggy says, "No, we're not tracing the call." And the caller says, "Well, why the hell not?" Right? So that's, I think, a really good demonstration of the other side of her ambivalence, which was there all along, but for whatever reason, she couldn't really come out with it. And I have to say, this final bullet point here, that there are probably thousands of times in my career when I've said to someone, it sounds like partly you want to live and partly you want to die, which obviously is a statement of ambivalence, and that people always resonate. I can't think of any time when someone said, "Well, no, that's not what it's like." People always relate to that. And I think it helps them understand how they're feeling too, because it can be obviously very confusing and upsetting to have these suicidal thoughts. So as an example of ambivalence, we have the situation that's an empirical finding that there's a very high suicide rate of people right after they've been discharged from a stay in a psychiatric hospital. And as I said, this is an empirical finding. We can all give our guesses or our thoughts about why this might be true. There's no way to know for sure. But one of the striking parts of this finding is that the highest rates happen right after the end of the hospitalization, and then over time, the number of people per unit time goes way down. So in the Pokorny study that we talked about before, remember that, the guy who came up with the 4 variables to try to predict suicide among his sample of a couple thousand people, but still, even using 4 variables, it was remarkably not accurate. That in that study, he obviously kept track of when people killed themselves after the hospital, and 5 of them died in the hospital. 10, now remember there were 67 altogether, 5 in the hospital, 10 in the first week, and 6 in the first month. So that's 21 out of 67 in the first month out of the hospital, and then the rest of them kind of sprinkled out over the next 6 years. So actually one takeaway from that is it is a risk factor for suicide of someone who's just been discharged from a psychiatric hospital. And generally we think about that risk period as lasting about a month. But then the question, though, is why is that? If people are coming out of a hospital, you'd think they would be suicide-proofed, right? They'd be doing better. And, one explanation is just, out of a certain number of cases, some people are just not going to get better. They're not going to receive adequate care, or for whatever reason, they're just as bad. But I think that although that may be true, I think another factor here is ambivalence. In other words, people make a suicide attempt, and as I said, it's so common for them afterwards to say, "Oh, I'm really glad I'm still alive. I can't believe I did that. Why did I do that? What came over me?" And if that's the case, and if they're in a hospital, then the staff is going to write down in the chart, "Patient no longer suicidal." And if that goes on over a period of days, the hospital staff might think to themselves, "Oh, the treatment that we are offering this person is working. And look, as evidence of that, they're no longer suicidal." And so after Back in the past, it might be a couple weeks. These days, it might be after 4 or 5 days or maybe a week of repeated statements that they're no longer thinking about killing themselves and why did they ever do that, and they feel differently now. They get discharged. And my point is, really, maybe nothing changed. Maybe whatever treatment, which unfortunately these days is often just throwing medication at people, whatever treatment happened in the hospital had nothing to do with it. It's just that their ambivalence shifted after they made the suicide attempt. They felt no longer suicidal, but now they're discharged, and after they're out in the community now for 2 or 3 weeks, right back in the same situation, right back with the same stressors. None of the external conflicts or none of the internal conflicts have really changed. A lot of people don't follow up after they've been discharged from a psychiatric hospital, and now 3 weeks later they're back where they were before, and some of those people kill themselves. So I think this phenomenon of increased rates of suicide right after discharge from a psychiatric hospital might well be another example of ambivalence in action. All right. So I hope you can get this, and we can, as we go forward, keep in mind the idea of suicidal people being ambivalent in a variety of different ways. I'll come back to it from time to time, and this will be one of the background kind of concepts that will bring to the issue of the clinical aspects of suicide prevention. All right, so I'll see you next time.